Hello, my name is Tom Vetter. I'm the Vice Chair and Division Director of Pain Medicine here at the University of Alabama at Birmingham. I think the primary advantage to our pain management program here at UAB is that we treat the whole patient. We take a holistic approach that involves not only treating the biomedical component of a patient's pain, but also their psychological and social elements as well. Well, oftentimes patients who come to us have been seen by other specialists who are focused in other areas other than pain medicine. And with good intentions, those physicians have taken care of those patients. What we do is collect those various records from outside physicians and other pain medicine programs oftentimes, review those, not necessarily to second guess what other physicians have done, but to see if there's something else that might be possibly to be offered to these patients. I think one of the unique things to UAB in general is that we are an academic medical center. And for many folks that represents a bit of a turnoff, including referring physicians, because they're concerned that if they send a patient to us, they'll lose control of that patient or continued care of them. And many patients coming from outlying areas find it somewhat challenging to come to UAB because we're located in an urban setting. But I think the upside to that is, as part of an academic medical center, we are on the cutting edge of research and adopting cutting-edge technologies as well as medications and other multimodal therapies to treat chronic pain, which, as most people appreciate, is a very complex phenomenon. Well, one example comes to mind is the use of radiofrequency ablation and the diagnostic tests that go up to whether a patient is a good candidate for what we call RFA. I focus a lot on the geriatric population, and many of those patients have degenerative disc disease, facet joint arthropathy, and chronic sacroiliitis. And they undergo conventional interventional procedures that may provide them with 2 to 3 months worth of pain relief at best. By doing diagnostic tests, we can fine-tune or focus in on the specific area or pain generator, as we call it. And then if they respond to a series 1 or 2 of diagnostic blocks, we then can go on and do a therapeutic radiofrequency ablation, or RFA, of the nerves that are innervating those parts of their spinal column as well as their pelvis and hips. The question of multimodal analgesia is directly related to having multiple specialties involved. One of the challenges, as I'm sure the audience can appreciate, is the old expression, too many chefs spoil the soup. And so what we sometimes see are patients who have been to multiple subspecialists as well as multiple pain physicians, and their care has been somewhat fragmented, for lack of better words. One of the things we take pride in and really attempt to do is to bring those various specialists to the table, if not literally, figuratively. And so we reach out to our colleagues in physical medicine and rehabilitation, which includes physical therapy and occupational therapy. We reach out to our colleagues in neurology. We also reach out to our colleagues in psychiatry, specifically to psychology. And we've been fortunate over the last 3 years to recruit 2 very talented pain-focused clinical psychologists who practice within the 4 walls of our clinic. It's interesting that fellowship training in pain medicine approximately 4 years ago put out a new set of requirements. And those requirements included a close collaboration among anesthesiology, physical medicine and rehabilitation, neurology, and psychology, which also includes psychology. So we're just generally following the national trend of fellowship training requirements, but it obviously has many advantages to patient care as we bring those other experts into the care of the patient. Well, the geriatric population to me is very important. The early part of my career I focused on the other age spectrum, which was the pediatric population. And folks that have known me for the last several decades find it interesting or ironic that I've now gone to the other extreme of the age spectrum. But I don't find that incongruous, because both populations tend to be vulnerable, tend to be a bit underserved and undervalued by our society. They have unique pharmacokinetics and pharmacodynamics in how they handle medications. What I find particularly enjoyable about the geriatric population is that their expectations are much more realistic in terms of what they're looking for from a pain management program or from a pain medicine physician. What I mean by that is, they want to get back to some routine activities of daily living, which includes interacting with their family, particularly children, grandchildren, being able to go to church, being able to go and engage in other social activities. Most, if not all of them, are retired. And so working in close concert oftentimes with our geriatricians, who are currently a good source of referrals for me, but as well as the primary care physicians in internal medicine as well as family practice, these people come to me, or these patients come to me on multiple medications, given the fact that they have a lot of chronic comorbidities, and we have to be very mindful that there's drug-drug interactions. And oftentimes what happens is patients will be put on a series of medications and no one will stop and actually review those comprehensively and say, well, is this medication still working for you, or did it ever work for you? And if they say no, well, that's one medication we can take out of the equation, which can very readily interact perhaps with other medications we want to start. So I think one of the key things about geriatrics is, one, acknowledging that their pain is real and that their pain is important, because I think a lot of the older people in our generation, older generation in our population, tend to be somewhat dismissed, as if, well, you know, you're 70, 75, pain is just part of the natural aging process. And I very much disagree with that. And so it's very gratifying when a patient comes to me and we start them on a low dose of medications along with discrete nerve blocks, including lumbar epidural steroid injections or facet joint injections or SI joint injections. And we do that in a sequential fashion so that we can best identify which of those might be the pain generator. And I've been extremely gratified by how many patients we've been able to help get back into a normal routine for themselves. One of the other things that we really emphasize here at UAB is a patient-centered approach, and that includes in the management of pain. And I'll speak specifically to the geriatric population. What I find very gratifying is that more often than not, if the spouse is still living, they are an active member or an active participant in their loved one's care. And it's very gratifying to involve them in decision-making, this shared decision-making concept. So not only is the care here at UAB very patient-centered, it's also a shared decision-making process. And I find that particularly gratifying in the geriatric population because, let's face it, they've lived a very long, generally very productive life, have been very independent, and now they're entering into a phase of their life where they're more dependent on people around them, which can oftentimes be very challenging. And so when the spouse is participating, when their children are participating, or grandchildren even are participating, it's very gratifying. It's a term referred to as social capital. And oftentimes we don't, I think, as a healthcare system in the United States, tap into that really generous social capital that many of these older patients have. The other thing that I want to touch upon is that, not surprisingly, as people get older and their functional ability becomes somewhat diminished, it's not surprising or unexpected they develop some degree of depression, as well as potentially some anxiety, especially if they have life-threatening illnesses that they're grappling with. And one of the things that I also really try to emphasize without being overwhelming with it or overburdening is to talk about, do you have any coexisting anxiety and depression? We routinely screen for that in all patients that come to our clinic, but specifically in the geriatric population, because I think we do our patients a disservice by not recognizing comorbid anxiety and depression, because it undoubtedly exacerbates their pain intensity as well as their overall suffering. That's where our pain psychologists also come into play. Dr. James Weisberg, one of our clinical psychologists, has a specific interest in the geriatric population. So he and I will work very closely together to assess these patients for their degree of comorbidity and depression, but also cognitive dysfunction, which is another issue that can be very challenging in the older population. It's not uncommon as patients grow older that they develop degenerative joint disease, involving not only their knees, but their hips, shoulders, and those are joints that everyone can appreciate, and not just patients, but various clinicians. Those degenerative joint changes likewise occur along the entire vertebral body. It is often under-recognized, both in the primary care community as well as in other subspecialties, that can be the pain generator. And those patients can respond very favorably to discrete interventional blocks that we perform in our pain clinic. So it's not uncommon for a patient to be sent to me in whom a combination of prescription medications as well as non-narcotics as well as discrete nerve blocks targeting specific areas of the vertebral column as well as the sacroiliac joint, the greater trochanteric bursa, can bring about dramatic improvement in patients' pain and therefore improve their quality of life. Well, I think a very important point is that we enjoy collaborating with the primary care physician. They're a very, very important co-partner in the management of patients with chronic pain, especially the geriatric population. These primary care physicians, whether they're formal geriatricians or not, have been actively involved in the care of these patients, oftentimes for decades. And they're a trusted partner. They're an ally. And I stress the importance of that primary care physician being an active member of the pain treatment team. And so I enjoy ongoing dialogue and ongoing communications with them. And I strongly encourage patients to maintain a strong relationship with their primary care physician, both now and going forward. Well, I have a different perspective on how we can improve the pain management program here at UAB, partly again because I focus on the geriatric population. And I think an area that I'm excited about is the ability to bring in pastoral counseling. This being Alabama, there are a number of individuals who are more comfortable, I sense, with a faith-based approach to psychosocial issues and spirituality. So one of the exciting opportunities that we have is to bring pastoral counseling into our clinic. And with the renovation that was completed in March of 2014, we now have the capability to bring both social work, which I think would be very advantageous, as well as psychology, which we currently have on the ground, but also to bring pastoral counseling in for those individuals who would feel more comfortable in tapping into someone in a faith-based kind of spiritual approach to their chronic pain and suffering. I think I can speak for not only myself, but all of my colleagues in the pain management program here at UAB, that we view it as a real honor to be able to take care of a patient, both to have a patient referred to us by a primary care physician or from one of the other specialists taking care of them. But as I say every time I walk into a patient's room, not only do I shake their hand, but I thank them for giving me the opportunity to take good care of them.